get through as many of these slides as I can, and then we'll leave some time for discussion. So the last time I was in this facility was January of 1983, and we weren't called OSU in those days. We were called OCOMS. And I did an ER rotation in January of 83, so it's been a while since I'm back, although I do come to Tulsa on a fairly frequent basis. Just don't get over here very often. Here are our objectives. We're going to talk a little bit about the literature, about some paradigm changes. We'll talk about what we do. We have a 4-hospital system in Chicago. It's owned by Tenet Health, at least for now, until they decide to get out of the market. And I am the medical director of 2 of those facilities, but I am the president of the organization that covers all 4. So here's the old paradigm. The old paradigm for a long, long time, for those who have been around for a long, long time, is basically the 10-30 rule, where transfusions were used to maintain a blood hemoglobin concentration above 10 and a crit above 30. There was a concern regarding blood-borne pathogens in the 80s that stimulated a lot of lab testing of blood prior to transfusion. In 88, the National Institutes of Health Consensus Conference on Perioperative Red Blood Cell Transfusion suggested that no single criteria should be used as an indication for red cell component therapy, and that multiple factors needed to be integrated, the most important being the patient and the clinical active. So in the last 25 years, a ton of evidence has been put out there about the guidelines for red cell transfusions, and it's still moving and evolving, and we're going to talk about a few of those. The common theme among the guidelines was that there needed to be a balance between the benefit of treating the anemia and the desire to avoid the unnecessary transfusion-related products. In the 80s, that was infection, hepatitis being the number 1 infection that we were concerned with, and HIV subsequently to that. And this required a lot of integrated dialogue between the clinical practitioners transfusing those units and the safety on the blood procurement folks. And when I was in the military, that was a big deal. It was not uncommon for us to draw 600 to 800 units at one draw. So why? Well, there are some issues, and there are some reasons why we should be judicious. Well, 1 is it's a resource. 2, it's expensive, and some of the clinical manifestations of storage have some consequences. Here's just a good illustration with a scanning electron micrograph of what red cells look like following storage. Day 1 of storage, they look pretty normal. By day 21, even in a preservative, you can see the crenation that occurs within the red cells. And by day 35, not only are they starting to crenate a little bit, but they start to get really sticky. So you lose some of your oxygen carrying capacity, and they become adherent to the capillary walls following transfusion. What else can happen? Well, you can have impaired tissue oxygenation. It stimulates the procoagulation process when you transfuse somebody, and there is a component of immunosuppression. And a lot of the orthopedic surgeons and a lot of the big joint replacement folks will tell you that storage and the methods we use to store blood products have an immunosuppression factor that they see not necessarily quantitatively, but qualitatively in patients who require transfusion following joint replacement. Blood is a liquid transplant. I think if we can come to that agreement, we start to think about its use in a different mindset. If you think about blood like a transplant or a drug, it starts to take on a new awareness, a new appreciation for what you're giving somebody. As a transplant, it alters the recipient's immune system. Each transfusion means there's a new exposure to a new donor and a new immune exposure. 1 unit of allogeneic red cells may increase the risk of nosocomial infection, at least in some studies, by 50%. I'll show you some papers as we click through this that talks about the increase in post-operative infection, the increase in ventilator-acquired pneumonia, the increase in central line sepsis. And I know that we're all fighting that issue. The threshold for central line infection is 0, right? So, at least in our facilities, you know, we struggle with this. We have whole processes. We have equipment. We have all sorts of stuff to get us to zero. And then the other one that all of your hospital administrators are concerned about is it tends to increase the length of stay. I'm going to go through some of this, but this is just an illustration of there's a lot of stuff out there. There's a lot of literature out there talking about why you should be judicious. You know, this slide is the other arm of that, which is the regulatory agencies. Transfusing blood has an awful lot of people integrating and touching your transfusion service. You know, you don't think about the Department of Transportation, Homeland Security, Environmental Protection Agencies, the Nuclear Regulatory Commission. All of these agencies have some contact somewhere with the blood utilization program, your transfusion medicine services. So in 2012, the proceedings from the National Summit on Overuse put out the following statement. Blood management performance measures were coming to a hospital near you. That statement was put out by their consensus statement. The USAA in the next year put out an article that talked about patients receiving too many blood products, and they're more likely to experience medical complications, including infections and organ damage. Well, if USAA is putting it out, it has to be true, right? Well, but if it's out there for the general public, then people started to ask and continue to ask, is it medically necessary? I'm going to rephrase the paradigm at least a little bit. And the paradigm, the old paradigm was blood is safe so long as infectious disease can be screened effectively, and you should never transfuse just one unit of blood. When I was a resident in pathology, that was a rule. One of the utilization criteria we used to use was if a physician ordered a single unit transfusion, we questioned whether or not he needed it. Now, of course, that's not the case. You should only transfuse one, check, and then transfuse again if you need to. The new paradigm basically says less is more, and stored blood has inherent potential problems or is potentially injurious, and the FDA would never have approved blood in its current state as a biologic agent. So what are some of the references, some of the background, some of the support for us to make these kind of statements in our blood utilization programs? Well, in 1999, Herbert and a whole bunch of people did the TRIC trial. What they did was they looked at 838 critically ill patients. They randomly assigned them. They used a restrictive transfusion cutoff, which was less than 7, versus a liberal transfusion cutoff, which was less than 10. And what did they find? They found that a restrictive approach was at least as effective as and possibly superior to the liberal approach in critically ill patients. They had the caveat, though, that with one exception. Patients with acute myocardial infarction and unstable angina. We're going to come back to that because subsequently reviews and subsequent papers have said that even in those patients, the outcomes are at least as good, if not better. Well, a lot of clinicians, at least in our facility, we have several docs in one of our hospitals who come back and we started this. They said, well, you didn't say it was always better. You said it was just at least as effective. It wasn't, and I'm like, dude, listen, it's potentially better and it's no worse. You know, I'm not going to quote Donald Trump, but I mean, what do you have to lose, right? I mean, that was kind of that was kind of our approach. And it worked for a lot of people, a lot of our docs. But again, our docs are a little different because our hospitals are different. We have one hospital that is almost all orthopedics. I mean, orthopedics, high-end orthopedics. Like, people come from all over the world to have this one guy and his team replace joints that have failed. I mean, that's, and that, you know, he floats between the University of Chicago and this one little hospital. He is king of his empire. And so to get that hospital on board, you had to get him on board. And once he came on board, the hospital came on board. Getting him on board was an adventure, and I'll share with that as we move forward. So Rao, in 2004, looked at acute coronary syndrome. And what did he find? Well, he found that transfusion was associated with increased death at 30 days, okay? And what he recommended was caution for the use of red cell transfusion just to maintain arbitrary hemoglobin and hematocrit levels in otherwise stable patients with ischemic heart disease. So Rao's paper was the first to actually challenge the caution that Herbert and the New England Journal in '99 put out. In STEMI patients, Shishabor, in a large group of folks that studied over 4,000 STEMI patients, they basically took out a lot of independent variables and came to the conclusion that after adjustment for covariance, transfusion remained an independently associated increased length of stay, long and short-term mortality in STEMI patients. Again, what they're saying in all of these papers is, look, you're standing by the patient, you make a patient care decision. You know, no one is telling you that you as a cardiologist, you as an internist or hospitalist shouldn't make a clinical decision. There isn't a pathologist on the planet that is going to step into your world and tell you how to practice medicine. That is just foolish. You want a contract canceled, you start telling clinicians how to practice medicine. But what we will say, what we will tell you is, don't use any one variable independently and only, like lab tests. There is certainly some degree of variability in lab tests. Don't base your decision strictly on the hemoglobin or hematocrit. Base it on what you see in the patient. So Sherwood, in 2014, they looked at transfusions in percutaneous intervention. And what did they find? They found that that receipt of transfusion was associated with an increased risk of in-hospital adverse cardiac events. Now, you can go back and pull the data on what those in-hospital cardiac events were. All right? Death, stroke, MI. The great question, and the question you should ask is, was that related to the actual infusion of red cells, or was it related to a bad procedure or a bad, a bad use or a bad, nursing function, something else? Did you puncture something? Did they, those fall out of this. If you look at their data, it's pretty clean. And what they found was in about 1,400 transfusions was that there was a statistically increased incident of death, stroke, and myocardial infarction. So let's just to be fair, there are still papers out there and there's still data out there that isn't all supportive. So if you look at Murphy, Pike, Rogers, who are looking at cardiac surgery, and again, cardiac surgery today is different than cardiac surgery 10 years ago, right? I mean, we all know that. So what did they find? They found that a restrictive transfusion threshold after cardiac surgery was not superior to a liberal threshold with respect to morbidity and healthcare costs. So what they came back with was it wasn't any better to use a restrictive threshold of 7 or less. Well, but it wasn't, But they also came back and said it wasn't worse either. So this is out of fairness. In 2015, this article basically said it doesn't matter. Now this is where we got Dr. Finn, who is the orthopedic joint guy, on board. So one of the things about really, really, really smart people who are really driven, the cats that sleep 2 and 3 hours a day, they operate from 6 a.m. in the morning till 8 or 9 at night. They're just crazy people. And his team. We were at one of his department meetings, which starts at 6:45 a.m. every third Thursday of the month. And so when you're invited, you have to be, these guys are like the military. I mean, like Tom Coughlin with the Giants, in your seat 5 minutes ahead of time or you're late kind of thing. And we were talking about restrictive thresholds, and I provided them with some of this literature. This is the paper that caught their eye. They said, in elective orthopedic settings, the liberal strategy did not reduce the rate of death or inability to walk independently on a 60-day follow-up. He added to that he was seeing, not only was he seeing that, he was seeing that their patients who were transfused were having a slower time in their healing response. They were getting more wound issues. They weren't getting up and moving as fast. They weren't getting to the rehab as fast. And so he got on board relatively quickly and started to be a champion for us, which is huge. You get a clinician who's a champion for blood utilization in your hospital, that takes the lab out of the mix. Well, a little bit, at least. So here's another paper that I wanted to review that followed up with that. What we also talk about a lot is the rates of infection, either upper or lower respiratory tract wound inflammation, infections, and healing following allogeneic blood transfusion. Friedman's paper in 2014 supported what our orthos guys were telling us, which was, following total hips, total knees, and other arthroplasties. And again, for this hospital, they do primary joint replacements, but at least 2/3 of their joints are revisions, huge bloody surgeries. So for them to come to the place to say, hey, we don't need to be using blood products is a big deal. And part of it is the outcomes. What they were seeing was the outcomes weren't as good as they had hoped or expected following patients who have been transfused. Now, they do use the self-saver. They do use other means to keep their patients from requiring blood transfusions. But it was important for us to get them on board and get them participating and being champions for blood utilization. How about GI bleeds? Well, our gastroenterologists at all of our facilities are pretty conservative cats. I mean, we have one of our biggest GI guys, not just in terms of his volume, the fact that he's 7 feet tall and played basketball at Creighton. He is a real advocate for not transfusing, for using intervention and using supportive care whenever possible. And one of the papers that he actually referred to us to include in our educational program on blood utilization was this one from Villanueva. And basically, they looked at 921 patients with upper GI bleeds. And what they found was that the restrictive approach, using a threshold of 7 or less, improved the outcomes of those patients. Now, was that because they were given supportive care and were given endoscopic treatment faster? I can't answer that. But this I think is something that you need to kind of put in the back of your mind. What I'm talking about is I'm not telling people in our systems that you can't have blood. We don't do that. What we do is if you don't meet the criteria, which is 7 or less, we ask the question. And the question is an electronic question, and it's a blood bank question. Do you know, there's a script, and I'll share with you at the end how we do it. There's a script. We ask, are you sure? Are you sure? And now, if you're at 8 or 9, our blood banks generally ask you, the clinician or the residents, we have a lot of residents floating around, hey, this doesn't meet the criteria. It's an outlier. It's going to get flagged. You want to talk to the pathologist on call or our transfusion medicine specialist. The other one, and we don't do a lot of brain anymore at our institutions. We do strokes. We have 2 big stroke centers. But so one of the questions we were asked ourselves was, what about central nervous system, about strokes and traumatic brain injury? And unfortunately, those of you who know anything about the city of Chicago, it's not what it was when I went there. I mean, the west side and south side of Chicago is a war zone. I mean, it's an unsafe place. It's, you know, and it's regrettable, but our hospitals, while they are in technically the near west side suburbs, we are close enough to some pretty unpleasant areas that we get some overflow at least at one of our hospitals. They're on Austin. If you're familiar with Chicago, they're on Austin Avenue, which is right on the border of some pretty aggressive neighborhoods. So we see a lot of trauma in those hospitals. And so we looked at Robertson's review in JAMA, and basically what they said was, you know, in their paper was that, you know, the interventions that were studied, that if you look at a judicious use of blood products in traumatic brain injury, those patients tend to do better than people who are transfused in a liberal fashion, which is even less than 10. So this is his breakdown, the data that he provided for us in that paper. And what he asked was, would a hemoglobin threshold greater than 10 improve outcomes? And in fact, not only did it not improve outcomes, but it made things worse. And for the traumatic brain injury patients, this is what everybody was called to attention, was the thromboembolic events following transfusion thresholds. Remember, I showed you that not only are transfused red cells stickier, not only do they stick together more because of their storage properties, they also stimulate the procoagulation cascade, even in small ways. In this patient population, that has an adverse outcome. Is there an impact on cancer recurrence? Well, this one's harder to really get your arms around. But in a review of about, I want to say 36 studies of 12,000 patients, 23 of those studies showed an adverse or less favorable outcome in patients who were treated perioperatively with blood prior to their cancer surgery or for colon cancer. 14 showed that it was an independent factor, but it was more dose dependent as to how much blood you got, and that tended to be related to what type of surgery you had and how big and aggressive it was. You know, when you watch some of our gynecologic oncologists work, you know, some of the stuff they do on some very advanced cases is pretty aggressive. And even though they use the robot and they do all sorts of other really cool stuff, the surgeries those guys do is really intense. And so, you know, I can see where that would be the independent variable. Infection rates. So this is probably if you're going to use blood utilization literature, this is probably the one that everybody comes back to, which is Taylor's paper in 2002. And what they basically found that for every unit that was transfused in patients in a hospital setting, the odds of nosocomial infection went up by a factor of 1.5. Now, it was dose dependent, yes. And was it related to, you know, the function, the nursing care, if you will, the transfusion procedure, if you will, you know? And again, when you talk about central line infections, when you talk about, you know, infection rates, that's obviously a question. But again, when you're sticking needles in people's arms to administer a product, that's a risk. This isn't an inflammatory statement to nurses. My mom was a nurse. I have two sisters who are nurses. You know, I've been a patient often enough that I love nurses. I love great nursing care. But it is a function of what they do in transfusion, and you can't ignore that. There is always a risk when you stick something into somebody. So what does Hill say in the Journal of Trauma? They basically say the same thing. If you look at the meta-analysis, there is an increased risk of postoperative bacterial infection in the surgical patient with blood transfusions. So septic shock. So what does Holst talk about in the New England Journal? Well, they talk about this, they're talking about, are patients going to get, are they going to be worse or better? Is it going to have any mortality effect? And what their paper basically said was, if it was very limited. About 45% versus 43% if your endpoint was 90 days after randomization. Not as striking as you would have expected given the other two references that I gave you. Ventilator-associated infection. Well, Shore and his colleagues in critical care in 2004 actually showed that there was an adverse outcome for patients who were on ventilators who required blood transfusion. Again, infection rates went up. Healthcare-associated infection risk in red cells with leukoreduction. Did taking white cells out using only leukoreduced blood products decrease the infection rate? Well, if you look at this paper in JAMA in 14, it does help if you use the restrictive strategy. But again, leukoreduction in and of itself didn't seem to change things, which again probably talks about a procedural process. LaCroix, what did they talk about? Well, I don't want to limit this to just adults. If you look at the pediatric patients, and I mentioned to somebody this morning, my second daughter is a peds resident at Children's Hospital of Michigan. Huge place. It's got tons and tons of stuff. And in their practice, in their hospital practice, they have a very aggressive blood utilization program. And in large part because they found in one of their studies that a non-restrictive transfusion criteria basically showed that their patients had worse outcomes when they had to transfuse blood. Now, maybe that's because of the disease state. I'll grant you some of that. But they believe that multi-organ failure in particular in pediatric patients goes up if you use blood products in a liberal fashion. Again, we're not talking about something, not talking about you looking at a patient who looks terribly sick and looks anemic. Yeah, we're talking about patients who otherwise could survive with not giving blood products, just using supportive care. And where does all this come back around? All that data is filtered by almost every different society that's out there. So every one of the societies listed here is got a published transfusion guideline. Okay? So every one of these societies has a published transfusion guideline. I'm going to focus my attention here, which is the AABB, the American Association of Blood Banks. But I want to, again, and so what is their criteria? What is their threshold? How am I doing now? So their criteria is that, and their statement is that a restricted transfusion threshold is safe in most clinical settings, and that the current blood banking practices of using standard issued blood should be continued. What does that mean? Well, that means that our blood overall is safe. The transfusion risks related to the blood itself are fairly small. That control for the procedural piece on the front end will help. And that patients do better if we limit the amount of blood they get and we think of it as a transplant or a drug. In 2016, the AABB published the following guidelines. And so I'm going to basically just, you can read this, but think about this. Anybody with a hemoglobin of 6 or less, flag should go up. There aren't many docs out there that aren't going to transfuse at 6. I get that. So that was their statement was people who have a hemoglobin of 6 probably need a blood transfusion. We're not going to talk about that. What about 6 to 7? Well, again, the AABB and most of the societies listed said, yeah, they probably need a blood transfusion. 7 to 8, well, 8 to 10 and 10 above, we kind of talked around this. There aren't very many indications. Now, 7 to 8, that's the one where that's where the rubber meets the road in terms of utilization. In our system, our threshold is less than 7. Less than 7 triggers go off in the system. Okay, that's where we've set our threshold to ask the question. Doesn't mean we won't transfuse at 7.4, 7.2. And again, the AAB says the same thing. It may be appropriate in certain patients. In a lot of the joint revision patients, the docs are uncomfortable at 7.4, 7.5. The patients don't look good. What they've changed, however, is used to be they would give them 2 units of packed red blood cells post-operatively if they were sitting at 7.2 or 7.3 and didn't look good. Now they give them 1 unit, wait, watch, reassess. That's a different treatment paradigm. They change their practice based on the evidence. Still doesn't mean that the flag doesn't come up, but our system, at least at the joints team at the joint university, we don't ask about 7.2. We take them off the board because their practice pattern is pretty consistent. The guideline emphasizes that the decision to transfuse should not be based only on hemoglobin levels. This is the take-home message of the talk. This is the take-home message to when I give this at all of our 4 hospitals. It's a take-home message. We talk to nurses, to our blood bank staffs. This is not about numbers. It's about patients. It's about patients, and the people in front of those patients are the ones who have to make this clinical judgment. This is the final common pathway right there. It's not about the numbers. The numbers are an indicator. The numbers are a guide. Again, that's the plan. It's, and our overview is that if we're going to optimize our transfusion practice, basically we need to provide enough red cells to maximize the clinical outcomes while avoiding transfusions that are unnecessary. Yes, that is, so what can we do? Well, you can dress up like Mike Moskowski, as my grandson is doing there, and run around the church parking lot recognizing that somebody in his world has decided to leave card trunkfuls of candy available to little people who can reach into the trunk. It was a really cool concept. Now, I doubt that works when you're talking a transfusion committee, but it's a nice break in this sometimes monotonous situation. What else can you do? Study the situation. Review your utilization programs. Talk about your nursing practices. And I'm sure you're doing it because all hospitals. Are there ways to improve our blood draws? Are there ways to improve the use of central lines? Are there ways to improve our transfusion procedures? And then, review your management systems and review your economic indicators. What else? Entertain and educate. Well, I'm not saying this is entertaining. I'm just saying that get out there, talk it up, change the paradigm. This happens to be a little lab note that goes out where this one is about C. diff, but in C. diff, talk about it. Put something out. Get people's attention. And acknowledge, that people, there's a counterintuitiveness to blood utilization because it's been out there a long time, and be sensitive to it. Just, try to get people to stop and ask the question. Choose wisely. This is the campaign we came up with. It was partnered with the with AABB and ABIM, the internal medicines. Don't transfuse more units than you need. Don't trans red cells in iron deficiency that are hemodynamically stable. Don't transfuse O-negative blood except to O-negative patients. I mean, these are just certain recommendations that we tried in 2014, and I'll show you the outcomes of that. Lab data, again, not sufficient. We reassess between each unit. We really do. Unless somebody is in an OR, ER, labor and delivery, and there's blood on the floor, which we don't stop. Those spots in our hospital, we don't stop and ask the question. The risk to patient care and the risk to the blood bank staff is just not worth it. There aren't that many transfusions that are outliers in those instances to really worry about. Implement pre-admission protocols for elective surgeries. Well, I think everybody's doing this. Minimize your iatrogenic blood loss. These are just some of the things that we did. I'm not sure how much erythropoietin helped with our patients. Our ortho service uses this pretty frequently. There are some of our cancer centers have patients from a long way out, and we transfuse 2 units just because of convenience for the chronic MDS patients and some of those. Think of blood as a drug. Think of blood as a drug. We scrutinize our hemoglobin values, but we don't get in the way of our blood product. We ask the question, but we don't stop. Our blood bank and our pathologists and our transfusion teams don't stop a blood transfusion. Again, you have a blood safety team. Yes, I know. You have a champion. That's the other thing. And again, look for your menu options. Think of blood as a drug. Would you ever double down on pharmaceutical doses for any of those? No. The answer is, of course, no. Education, advertising. We had a nurse. Unfortunately, she's now the chief nursing officer in another hospital because she is that good. But she came up with this plan. She had these screensavers were made up, posters were made up, and then mouse pads by the computers. So every time somebody went to use it, they saw this little advertisement, if you will, and it just a creative, out of the box thought that wasn't expensive to do, and we thought was helpful. Dose effects. What does it mean? Red cells. 1 unit raises the hemoglobin about 1 gram. Platelets. If you give the 6-pack, you're going to raise it you get about 30,000 out of that if in a stable patient. Plasma, we don't use it to correct our INR. Most people don't. Critical values. What is the appropriate critical value? So, if you look at this recommendation from the AABB, the critical value is going to be either 7 or less than 7 for most institutions. So when you set that threshold, it's 7 or less than 7. That's pretty consistent. Some places are still at 7.5. I think I just told you, for at least one of our hospitals, we really don't mess with the joint replacement patients between 7 and 8, even though it flags in our system as when it comes out less than 7. Reduce variation. You got to scrutinize and reduce variation and improve your ordering form. Populate, if you can, the last hemoglobin hematocrit so the doctor sees it. The red cell count, make sure they can see that. When it exceeds the threshold, put up a question. Make sure they know that this is an outlier. Let them, ask the question at least electronically without making them call the blood bank. Create an algorithm. One of the things that we did was we have an algorithm. We have a script. We asked them. We stop, especially if it's above 8, and we ask them to reconsider. Again, indications and contraindications. This is not new. You want to give people what they need at the lowest common denominator. Test menus. So what did we do? We changed a lot of this. We got rid of bleeding times. We added some platelet function tests and Verify Now and some of the aspirin tests. That was helpful. The one thing that we did that was really colossally stupid, and we didn't even think about it, we had created in our system a panic value for hemoglobin of 7. Our transfusion threshold was less than 7. So what were we doing? We were calling every clinician on every patient where the hemoglobin was 7. And yet that same doctor who wanted to transfuse because his patient's hemoglobin was 7 was being told that the threshold was less than 7. Really a brain-dead thought process that we never... It took us about 4 or 5 weeks to realize that we were calling doctors, telling them this is a critical value, and then telling them they couldn't transfuse. Not the smartest thing in the world. So we changed that, and now it's less than 7, so it matches. Does that mean that we have people that don't transfuse at 7.5? Obviously not. So get some help. Your administration is obviously got the value proposition. They want you to contain costs. And they want patient safety. Safe patients at an inexpensive price point is what MBAs love to hear. Get the medical staff champions. Get everybody on the same page. Lab techs, keep calm, call the doctor, but as pathologists, get them out of the line of fire. They shouldn't be the front line getting shot at by doctors who are busy, who don't want to be bothered by this. Turn in your dialogue and you turn your script into one about safety. Encourage your docs by that you're doing the right thing by asking the question. You're keeping your patients safe. We call our blood bank medical director or our transfusion medicine docs on a regular basis, and that we know that's going to come in. And we ask our blood bank staff, whenever they're uncomfortable, they let them know, hey, would you like to talk to our pathologist on call? Would you like to talk to our medical director of the blood bank? Would you like to talk to our transfusion medicine specialist? Our triple threat here, if you will. We engage the ordering physician one-on-one in time. And if it's really outrageous, and there aren't very many of those, we'll do a peer-to-peer, review. We'll bring it to our chief medical officers if it's something that is really an outlier. Well, we haven't had very many of those. And again, engage your nurses. Make sure that they're comfortable understanding what's going on. And again, remember the value proposition. Make sure you have a script, and make sure your staff, especially your blood bank staff, have backup. There's somebody there that they can talk to, and that they're not on the front lines alone and taking the heat for something. So what do? We really beat this point home. It's not about data. We dropped our hemoglobin values, and we switched to leuko-reduced blood products. We moved our critical callback. I said we changed our benchmark for callbacks, and we basically allowed our CPOE. We took it to a default of 1 unit. You have to actually go in and manipulate it to order more than 1 unit at a time. We did, again, move to leukoreduction. What doesn't work? Well, so what doesn't work? The blood bank police. Even though what I've described to you sounds a little bit like police, it's not so much police as it is more crowd control. It doesn't work. It alienates people, and it impairs your relationship with your doctor. The professor, you're not the expert. You're not standing in front of patients in terms of pathology in the lab. You don't want to be the expert. Get out in front of this as a patient safety, improving patient outcomes. You're not the lawyer, but you're not negotiating with them. Your job is to ask the question, remind them that there are guidelines and thresholds. If they want to make that clinical decision, that's fine. That's their job. That's their role. That's what they're called to do. So what does it mean? What did we see? Well, we saw a consistent downward trend. And does it pay off? This happens to be my youngest child. They played Indiana University. This cat here is projected to be the 4th pick in the NBA draft. We kept it close for about 2/3 of the game. And Robert's about 6'7". I don't know if I have a picture of him standing next to this dude, but he gets dwarfed. This is what our hospital utilization did over a similar period, and these are what the savings were. I mean, we're not talking about insignificant savings in 14 through 16 for blood utilization. Lastly, it's really as all of us as clinicians and as pathologists and as laboratorians, it's our moral and fiduciary responsibility to be responsible stewards of these products. Now, I have no idea what my grandson is doing. This is at his great-grandparents' home in Indiana someplace. But I thought, that's about the way a lot of our blood bank staff look after a long night with a couple of traumas and a heart that goes bad. So, I'm sensitive to that. And I'm sensitive to the fact that this is a difficult process. If you live in Chicago, finding blood products is something that is, especially following holidays, is really, really difficult. And this is my son and his roommate. and they wanted a picture in front of the Assembly Hall National Championship banners, which I thought was pretty good. So this is it. I'm here to answer any questions. I will be as candid as I can with what we've done, what's worked and what's not worked. Are there any questions? Go ahead. CMV in radiation. Well, we have specific guidelines for the use of irradiated blood and CMV negative blood, and that would be post-transplants. And we don't see one of the things that we don't have is we have a neonatal staff from the University of Chicago who staffs our peds program, our deliveries and stuff. But any really sick kid is at Weiler's or at Lurie, right? I mean, in a town like ours, you know, we have two prestigious pediatric hospitals that aren't very far away. So any kid who's really, really sick doesn't stick around. So we don't really have a need for we don't have that need like for irradiated blood in CMV. If you're worried about graft versus host in a post-transplant patient, we'll get some requests for that. But I don't know if I'm answering your question, but so when a doctor goes in and wants to order blood in CPOE, so they have a default for 1 unit, and there are some special instructions. There's a special category. For those types of things, the box that comes up, if they check CMV, is for graft versus host, pediatric, there's 3, I can't remember all off the top of my head. And that's what, if they check those, the order goes through. If they don't have one of those checked, the order doesn't go through, and it defaults to please call the blood bank. And again, I'm assuming you might be a blood banker, so if you're a blood banker, you're the one that you're going, well, that just puts the blood bank right in the center. So what happens then is that the clinician calls, or whoever's putting it in, but usually it's a resident, he calls the blood bank and says, Dr. So-and-so wants to give CMV negative blood or irradiated blood, and that triggers a call to whoever's on call for the hospital in our lab, and they ask the question. They get the story. Will we do it? We will, but we use the American Red Cross now. It was LifeSource. The American Red Cross, their lab is in Peoria, Illinois, which is for us is about 2.5 hours away. So it gives us a little bit of lead time to get that kind of that to resolve that. Not very often. Did I answer your question? Okay. Anything else? House staff and residents got to go to work, and they're like, got to get out of here. No, so it's okay. Any other questions, comments? Yes, sir.
What are your thoughts on the new literature that the body wants to bring patients to take the
So, yeah, so the surgical literature talks about a 1-to-1 ratio, and so our surgeons depends upon, again, I'm going to back out and back into this a little. Depends upon the facility a little bit. So we have 4 hospitals, and 2 of the largest of which is about 470 beds, 480 beds. And our surgical team there is a little more aggressive. The gynecs, the cardiovascular surgeons, I think they're more attuned to this than, say, the general surgeons, the ortho guys. The ortho guys in our facilities tend to be very, very restrictive. And a lot of it, some of it's from the data we showed here, some of it's from some front-end discussions, some of it's from the chances, but a lot of it has to do with their observation of post-operative response, outcomes. They saw or see, and I don't know if they've written it up, but I know they've got data to put it together. A couple of their fellows and residents have a paper that they're working on that looks at patients getting to the rehab unit and a slower transition time to the rehab unit. I don't think it's out there yet. They've asked for some information to put into the poster that they were doing, but I don't know if that answers your question. I think it's probably it's going to be more driven by the patient population and by the surgeons treating those patients. My guess. Does that answer your question or not? Yeah, it's a half-assed answer. I'll give you that. Oh. I'm sorry, I misunderstood what he was asking. So our massive transfusion protocol is one that because we're a tenant hospital system, we crafted it with all of our different facilities, and it is a 1-to-1 ratio. So in that answer, that's 1-to-1. So yes, our massive and it's very similar if you're familiar with what they do at the University of Chicago. I don't know how much you guys get up there. We took pieces of that, and then we got into a big group over electronically, our blood utilization people, our transfusion medicine specialists, and then people at Hahnemann, people at DMC, Boston, San Antonio. They all got together, and then they crafted a system-wide massive transfusion protocol. We don't use it as much as you think we do. Our hearts will use it sometimes when things go bad. We've had a labor and delivery crisis. We have a fairly active L&D department with drop-ins, and then the Gun and Knife Club at one of our hospitals is pretty aggressive, so they use it quite a bit. Does that answer your question? Is that fair? All right. Anything else? Well, it's been a pleasure. Thank you for letting me come. Have a good day.